So it's now my task to put something together, so clinical case and some conceptual ideas that would allow us to judge to which extent respiratory mechanics may guide ventilatory settings. As you have learned, because Alain has done it perfectly, there are many things that could or can be measured around respiratory mechanics. Finally, I reduced the clinical cases to two ways of measuring physiologic or respiratory mechanics, and just to prepare that, we go roughly through some respiratory mechanics that might be effective in being a guidance to setting ventilatory settings. So I would like to start with the alveolar ventilation and dead space ventilation. You are all aware that the anatomical dead space is roughly, so we have to go through some numbers, 120 to 200 ml, and there is the famous VDVT, dead space quotient, which is at rest roughly 30% of tidal ventilation. So, and then we keep in mind functional dead space is anatomical dead space plus the alveolar dead space. So the respiratory tract physiology leads us to the anatomic dead space, which can be calculated either by the Bohr formula, which ends up with a dead space of 150. The rule of thumb to come to the dead space is body weight times 2 in ml. However, anatomic dead space cannot, that's something we know, be predicted the same as with lung size and the consequences in elastance by body weight. This is just by Brewer. It has been published in 2008. And as you can see, so dead space has a quite high variation and is not related to body weight. So what are the consequences of dead space quotient and functional dead space increase during RDS? That's the reason why we need such high alveolar minute ventilation to eliminate CO2. So we need an extreme increase in minute ventilation to reach a level, a quite acceptable level of CO2, and we all know that at the very end, to achieve this level in a baby lung would mean either to increase pressures or tidal volumes in a way that definitively increase stress and strain. We already learned this morning that an increase in the dead space fraction is closely correlated to the death of the patients, the mortality of the disease. And this is quite logical because it indicates the amount of lung areas that could be ventilated while using the actual setting. We have seen this several times. So now the question is, is there a way to get access in a precise way to the alveolar dead space and to the ratio of dead space to tidal volume ventilation? And without going too much into details, so volumetric capnography is one of the things where you are integrating flow and CO2 production. And finally, it gives you a typical waveform which would allow you to say, well, the phase one, it corresponds to large airway ventilation. The phase two is mixed large airway and alveolar ventilation. And the phase three is exhaled volume of alveolar gas. And this corresponds to dead space, this to pulmonary perfusion, and finally this to gas exchange. Or to do it in the other way around, as you can see here. So this is the way how with a single breath waveform analysis, you are finally able to detect or to determine the volume of the alveolar dead space as an exact measurement and to correspond it to the alveolar ventilation. Well, so we learned already this morning that there is the pressure time diagram during volume controlled mechanical ventilation. It was Giacomo who was reporting about it, so inspiration and expiration time. And we learned that if there is no flow, we are close to the part where we are able to determine resistance. So the no flow phase, or the constant flow phase during volume-controlled mechanical ventilation is the part that, this has already been shown, was used for the stress index by Marco Ranieri, and it has been already shown the limitations of using this technique. But nevertheless, it's an indicator, an easy indicator, as long as you are using constant flow mechanical ventilation or volume-controlled mechanical ventilation. Well, next access, also mentioned by Alain Mercard, was to use the pressure-volume loop. And just to remind you what is going to happen during a volume-controlled ventilatory cycle, I just marked the points which are during the pressure the pressure changes during the ventilatory cycle, what is going to happen in the hysteresis curve. Just to make you aware, hysteresis is a physical phenomenon, and it describes simply that a material reacts different if you put the force on the material than when you remove the force from it. And that's the typical reaction of a lung. So if you put pressure into the lung, independent if it's the alveolar pressure or the resulting transpulmonary pressure, the lung behaves different if you remove this force than when you increase this force and start while applying this force. So there have been many attempts to the pressure-volume curve, and the idea finally was to be able to identify a lower inflection point and an upper inflection point, and the physiological rationale behind identifying these 2 points is given by this cartoon, and Luciano calls it, below this point we would expect the lung to make gymnastics, which would finally mean, this means cyclic alveolar opening and closing of lung areas. And we know that this type of gymnastics is not healthy, at least not for the lungs. And the upper inflection point would be reached in any case when we are applying a tidal volume that is at least expanding the areas of the lung that are able to be ventilated over the lung capacity that is going to be, let's say, in a safe range for the areas that can be ventilated at all. This is a marking of the ratio of an expiratory lung volume to tidal volume application. So, and just, there are, as far as I remember, 3 slides you have already seen. I can go over very quickly. So this is just to give you again the relationship between inflection points and chest wall mechanics. So this is again compliance. And as you see, if the described function of the chest wall, if it's a chamber with a low elasticity, as you can see on the right side, so much less from the given alveolar pressure is a force that allows to expand the lungs. The driving pressure is the resulting transpulmonary pressure, which is in the right case extremely low. And if you imagine here would even be no surrounding of the lungs, it's extremely high. This is going at the same given air pressure to expand very fast, close to total lung volume or capacity, or even above that, whereas this, just by the given surrounding, is, if you want to say so, protective for the lungs at the same given pressure. You have seen this before. So the measurement of the steady compliance goes along the pressure volume curve, and it's the tangents alpha function of the inflating limb of the pressure volume curves, which allows us to estimate or calculate the static compliance. Normally in clinical practice, there are, let's say, 3 more or less established ways to do it. The classical sense was the super syringe, a calibrated syringe which would allow you to apply in 100 ml steps up to and above the upper inflection point in stepwise approaches 100 ml until you reach the upper inflection point, and then to go the same way back while reducing with each step 100 ml. The low constant flow way, as it's established in several ventilators, has been described by Alain Mecquard. And there is another way to measure it, which has been established in some ventilators. It is the called SCAS system, which is a steady compliance, which is finally calculated by automated single steps adapting it. The most easy way seems to be low constant flow, as described by Alain. However, whenever you did low constant flow in a serious sick patient, you are starting to sweat, because it's really low constant flow, really low constant flow. So if the patient has a PaO2 of, let's say, 45 at this point, you are going to stop it because you are going to lose your patient. And that would be the point when Luciano would be right. You have been very smart to measure the length before, because you have to put the patient to the grave. So anyway, so all these measurements are quite compromising for the patients. And we did a large study in Germany, I think it was end of the 80s. And we used all the three of these methods, and in more than 2/3 of the patients, we were either not able to identify a lower or an upper inflection point, or both of them. So that's the reason why I'm extremely skeptic in using this technique to identify a reasonable lower and higher inflection point. We can skip the things about chest wall elastance. Just again, what was mentioned by Luciano, so it by far, while measuring esophageal pressure, we do not measure the intrapleural pressure, which would be the pressure that we would be really interested in. It's really the pressure in the esophageal space. And depending from many things, from chest wall compliance, but also from, are there any movements? Does the esophagus do any movements? Are there other things that are influencing the measurement? But you just keep in mind, these are the two ways how it may change. So either the chest wall compliance is decreasing, or the chest wall elastance is increasing, or the other way around. So if we go for transpulmonary pressure, and I'm going now close to start in a few seconds with the clinical examples. So this is the calculation that's behind. You know that it has this paper by Evangelina Akumanjaki, which was a nice review where we are actually standing, what we are knowing about it. You have seen these two slides again, just a few seconds before. And maybe just one thing again with regard to transpulmonary pressure and the relationship to strain. And as you can see, this describes exactly the specific elastance of a healthy as well as on a sick lung. And as you can see, they strictly, independent of healthy or sick, follow the same line. So you might be aware of this famous paper, which has been published in the New England Journal. I was a little bit skeptic about this paper, I'm still. Nevertheless, what it did, it looked for delta pressure between expiratory and inspiratory pressures, and found out this is related to a range of, let's say, tidal volume in a relationship to predicted ideal body weight. And if you look at the delta pressure, there was a threshold above which mortality increased when the delta pressure was higher. So, and this is, as you can see, happened in this case around 16 or 17 centimeters of airway pressure. So we are talking about airway pressure. This is a table which was published with a Talmor study, absolute transpulmonary pressures. I don't go into details. And I allowed myself to do a simple and very pragmatic calculation. I looked in this table and I calculated the delta transpulmonary pressure from the data from the Telmore study. So, because this is a driving pressure. This is a pressure that is really transmitted to the lungs. And if you look carefully, so in the conventional group, before the change of the settings, it's quite comparable. It's 10.5 or 10.7 transpulmonary delta pressure. And after the trial, it's 8 versus 7.3. All far away from the range that has been thought to be dangerous for the patients. Nevertheless, with a huge difference in oxygenation, so I think there are many things that have to be clarified and should be discussed. And I think if we look for delta pressure, the only delta pressure that might make sense as a value to which things could correspond is the transpulmonary pressure. So I'm going now to show you just, this is a way how we use transpulmonary respiratory mechanics in our setting. I don't say you should follow this. It's just to give you an idea what can be observed and what can result if you go ahead while using transpulmonary pressure measurements in combination with volumetric capnography. So that's something we do quite often and quite regularly in moderate and severe RDS cases. So this is a 53-year-old male patient. That's the chest X-ray. So the ventilatory settings before we did the measurement is, as you can see here, so it's a PEEP of 12. I don't go into details. PaCO2 is 37, PaO2 is 89, PF ratio 12. What about PEEP and dead space? So that's our interest. If you would, so we started to do some measurements. So volumetric capnography, as you can see, is the alveolar dead space is 88 ml, so it's 34% of dead space to tidal volume ratio, and at this time the PEEP, the settings resulted in a transpulmonary and expiratory pressure of -2. So then we shifted PEEP from 10 to 15, and as you can see, so there was an increase in PaO2 FiO2 ratio, there was a decrease in alveolar dead space, so the ratio, very probably because of the changes in tidal volume between dead space and tidal volume, was more or less the same, and we ended up with an end expiratory pressure, transpulmonary pressure of +2. So then the next step, we went up with a PEEP to 20, and so by transferring the slides, these things, as you can see, there was a decrease in the pulmonary, in the oxygenation data, and there was a clear change in the alveolar dead space, and we ended up finally with an end expiratory pressure of +4. So there was a deterioration with regard to dead space and with regard to gas exchange at a given end expiratory pressure, transpulmonary measured of +4. So then we went back with the patient to a PEEP of 13, and obviously, because there was no real washout phase, we shifted quite quickly between these things. There was the lowest VT ratio. There was the lowest alveolar dead space with the highest effect on oxygenation and CO2. And finally, we ended up at a transpulmonary and expiratory pressure of 0. Again, as it was already mentioned by Luciano, the absolute values for whatever, if you go for an absolute value, might not be the things that are really leading. We would say, well, if we would like to have a real effect, we would expect the transpulmonary and expiratory pressure to be above 0. But in this case, it turned out, I don't say the best, but it worked quite well in the patient. So that Then we tried to decrease even PEEP, and then we obviously reached de-recruitment. So again, the alveolar dead space increased, while the blood gases didn't change. So they stay in the same range, but there was obviously a de-recruitment indicated by an increase in the alveolar dead space. And as you can see now, we ended finally up in a transpulmonary pressure, which was -3. So that's combined with the effect on dead space, tidal ventilation ratio, and the total dead space was a clear indicator for the recruitment. Short second patient, because this is interesting because this patient was also moved from supine to prone, and we did similar measurements. And you are aware we did something that you will see in a few seconds. So this is the ventilatory settings. I don't go too much into details. So this is with a PEEP of 8 in supine position. And as you can see, the transpulmonary and expiratory pressure is -8. So PaO2 is 67, and as you can see, VT is 436, and there is a quite remarkable dead space ratio. And so we still in supine, shifted, we are still in supine, and as you can see, with an increase in the PEEP, there was recruitment, there was improvement of alveolar gas exchange, and there was a decrease in the negative value of the and expiratory transpulmonary pressure. However, it changed totally when we moved the patient to prone. So now we got a real increase because we got a change definitively in chest wall mechanics. And this still led to a negative transpulmonary pressure with a PEEP of 8 in prone position, but nevertheless to the changes in PaO2, FiO2 ratio that you can observe. But there is one thing I would like to make you aware. As you can see, this does not look very regularly. So with moving the patient to prone, obviously the patient was not deeply sedated enough, so the patient started to have some spontaneous breathing attempts, which was clearly to be identified and leads to the problem that we had to look for a time period in the tracing where you could find really stable values anyway. So with PEEP 15, again, the result, this ended up in the lowest alveolar dead space tidal volume ratio and ended up finally with a PEEP of -3, still minus, and at the same time with the best PaO2, CO2 answer. So to make a long story short and to summarize the patient, prone position in this patient led to a better oxygenation. The absolute, but at the same given pressures, the absolute dead space volumes were lower than in supine. And due to the reduction in tidal volumes, we observed very obviously increased dead space fractions. And PEEP titration, there was definitively a proof of recruitment. I'm sorry, Alain, and the transpulmonary pressure of 0 in this patient indicated the best, the optimal PEEP for this individual patient. It showed the lowest alveolar dead space, and this is the reason why we confirmed this as the best PEEP for this patient. So I'm going to close my talk, and my talk was to repeat or to report about respiratory mechanics for guidance. And I would simply, and I don't know if you agree, Alain, all parameters that are actually available require special setups and to be determined and to be applicable. All methods need specific knowledge and underlie errors, specific errors and limitations. As guidance should, and that's the most important thing, and has to work under dynamic conditions. We normally don't do a paralysis during the course of a patient to have stable conditions to measure respiratory mechanics. No single parameter can be expected, but the combination of methods might improve the evidence we can get from the measurement of respiratory mechanics. Thank you so much.